All right, thank you for the opportunity to speak to you on behalf of the APSA Ethics Committee, the Quality and Safety Committee, and the Outcomes and Evidence-Based Practice Committee. We're here to speak to you about transitional care programs in pediatric surgery. None of our speakers have any disclosures. Our learning objectives are there. We are going to review current data on transition of pediatric patients from pediatric clinicians to adult clinicians. We're going to talk about certain models to do so. We're going to discuss systems-based challenges that arise when working towards these programs, and we're going to talk about some of the ethical challenges associated with these transitions. So a little bit of background. This will be familiar to most everyone in the crowd. This is a growing issue. Children who had previously incurable disorders are living much longer, not just in pediatric surgery, but across the different pediatric conditions. Notable examples include congenital heart disease, sickle cell disease, and cystic fibrosis, where there are vastly larger numbers of adult patients than there used to be. We also have new unforeseen challenges with our own diseases. We have childhood cancer survivors with secondary malignancies, previous esophageal atresia patients who now have strictures and esophageal cancers, and patients with pediatric colorectal disease who now need lifelong management. It's very rare to find an adult surgeon who has training in pediatric surgery, and it's also rare to find pediatric surgeons who are trained and resourced to take care of adult and adult-sized patients. It's also a wellness issue. These issues are often managed by individual surgeons rather than on any higher level. So I'm going to talk a little bit about the ethical considerations. I'm going to talk about the four pillars of, or the four ethical principles: autonomy, beneficence, non-maleficence, and justice. So with respect to beneficence or doing good, we really need to make sure that our patients get the highest quality of care. And by keeping them in our clinics, are we omitting access to more adult-based care? We need to assure that psychosocial support is age appropriate. You know, at the point that you're 25 or 26, getting a sticker on the way out of clinic is probably no longer the right thing to do. And what we really ought to do is we need to facilitate and build trust in the adult team. And you'll hear about certain of these transitional programs that are based in other fields in pediatrics, and you'll note that they start at a much younger age than one would anticipate, even at as young as 10 or 12 years old. In terms of non-maleficence or doing no harm, this is part of our practice all the time, is asking the question, is the pediatric surgeon the right surgeon to operate on a given patient? And consider these situations: an 18-year-old male with a BMI of 40 who presents to your clinic with an inguinal hernia. That's a patient that I tend to refer away. I'm not the best person to do that operation. What about a 15-year-old female with a mass in the head of the pancreas? That's also one that I seek out help from an additional surgeon or a different surgeon to take care of it. So the scope of our practice is already very broad, and this is already part of our practice. Transitioning care or finding the optimal person to take care of an issue is already something that we do every day. Issues of justice or fairness or equity, we need to make sure that we have appropriate resource allocation. We talk about children's hospitals and the care of children and the limitations. And we need to make sure that those clinical appointments, those OR times at children's hospitals are allocated for children as opposed to it being limited by caring for adult patients. And we need to make sure that adult patients have equal access when they need it. We need to provide our adult treating colleagues with education about pediatric surgical disease so that they can provide the best care of transition. And we also really need to empower our patients. We need to make sure that they own their disease process, that they're aware of it, and that they manage their own care. One of the other issues of justice that we hear from our adult provider colleagues is that there's little financial incentive to take care of these patients. And this is a true systems issue that we need to address. And finally, with respect to autonomy or self-determination, it's really our ethical duty to support assent under the age of 18 and consent above the age of 18 as children become adults. We need to make sure that adolescents are trained in advocating for themselves and to make their own decision, although this may be challenging in certain of our patient populations who have special needs, such as developmental delay. And we really need to ask the question, whose responsibility is it to understand how to navigate adult healthcare systems? We need to empower our patients to answer that question and move their care forward. With that, I'm going to turn over to Dr. Acker and the rest of the Outcomes and Evidence-Based Practice Committee.
Thank you, Badr, for that background. So what is transition of care? The American Academy of Pediatrics defines it as a purposeful, planned process that addresses the medical, psychosocial, and educational and vocational needs of adolescents with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. So there are three main goals of transition of care. So the first is to prepare the patient for transfer, and the way we do that is by providing skills and knowledge about their own disease process. The second is to prepare the parents for transfer, because this is really transferring from a situation where the parents are in control of the medical decision-making to one in which the patient is driving the care. And so we need to prepare the parents for that. And then finally, to prepare and inform the health provider at the time of transition. So effective transition should promote continuity of care, improve and maintain disease control, increase treatment adherence and knowledge of disease, encourage autonomy and management, and increase patient, parent, and healthcare provider satisfaction. So why is transition of care necessary? I think this is a really interesting graph that's very relevant to us as pediatric surgeons. It shows the rate of increase of adults living in the United States with each of these index pediatric surgical diagnoses. So the way that these are listed in the table is inverse on the graph, but essentially by 2050, it's showing us that there are going to be over 40,000 adults living in the US with a history of gastroschisis. Rectal malformation is right below that, and then it goes down to myelomeningocele, EATEF, Hirschsprung's, CDH, and omphalocele. So this is our responsibility to transition these patients to adult care. So this is not a new topic. These are data from a survey that was administered to the APSA membership almost 10 years ago, where pediatric surgeons were asked, how many of you care for adult patients? So almost all pediatric surgeons in 2015 reported that they cared for patients up to 22 years of age. Half were caring for adults up to 26 years, 25% up to 30 years, and 13% of pediatric surgeons were providing care for patients over 40 years of age. And in this survey, the surgeons who responded said that there was a perceived lack of qualified adult providers, and this was the greatest barrier to transitioning the care of these patients to adult providers. So our aim as the Outcomes Committee was to conduct a systematic review of the literature to evaluate current transitional care programs in pediatric surgery, including their outcomes and the components of these programs. And so we asked three different questions. The first is, where do transitional care programs exist in pediatric surgery? And so the pie chart here shows the number of manuscripts that we identified in the literature evaluating or describing transitional care in pediatric surgery. And what you'll see is that the vast majority of the literature is from diseases that are primarily managed by the pediatricians and medical subspecialists. So 28% of the manuscripts came from inflammatory bowel disease. There's a large literature about solid organ transplant transitional programs. The congenital heart disease literature has really well-established transitional programs and data to support their programs. Spina bifida and neurogenic bladder represent about 20% of the literature, and then us as pediatric surgeons are this much smaller chunk of the pie, so we have a long way to go to add to the literature and build our programs. So within the pediatric surgery specific literature, we identified 19 manuscripts that were focused on index pediatric surgical conditions. The most robust literature is in anorectal malformation and Hirschsprung disease, with just a few manuscripts outside of those diagnoses. And then the majority of our literature are just needs assessments or survey studies, really asking surgeons, hey, do you have a transition program, or what do you think we need in terms of transition programs? There's only one series in our literature that actually evaluated the outcomes of an implemented program. That was an EATEF transition program. So to summarize where we have data in pediatric surgery, it's really very, very limited. Congenital colorectal is really the most robust literature, but that is not particularly robust, and the majority of existing studies are needs assessments describing the gaps in care or describing potential frameworks of care. So with that, I'll turn it over to Dr. Rebecca Rentia, who will speak to us about the next aim.
The next question that we looked at are, what are the clinical or patient-reported outcomes associated with transition of care programs in pediatric surgery? 23 manuscripts included outcomes of a transition program. 10 were comparisons between patients in transition programs versus not. 5 studies were program creation or the documentation of a new program implementation. 4 studies looked at surveys that were conducted to gather insights on the transition process. 3 were examination of the same group of patients both before and after a transition process, and 1 study was a mixed methods interview correlating with clinical outcomes. Of the studies evaluated, 22 of the 23 were inflammatory bowel disease literature, and 1 study was on esophageal atresia. When we categorize the outcomes, the count that these categories occurred in were most frequently improved quality of life. Next, improved disease control, increased adherence to treatment, and avoidance of unnecessary hospitalizations. In equal frequency were self-management skills, better disease knowledge, continuity of care, and positive interactions with healthcare providers. Evaluating just the comparative studies, in the 10 studies, the avoidance of unnecessary hospitalizations and improved disease control were the highest outcomes that were satisfactory in these studies. In decreasing frequency was increased adherence to treatment and improved quality of life. Looking only at the 5 studies where a new transition care program was initiated, these can be very variable from one-day experiences to a several series clinic visits. Improved quality of life and improved self-management and better disease knowledge were the most frequently cited outcomes. For surveys, improved quality of life, better disease control, and improved disease control were the outcomes most frequently cited. In summary, the best indicators of a successful transition program were improved quality of life, disease control, and increased adherence to treatment, and avoidance of unnecessary hospitalizations and decreased emergency services utilization. However, there's insufficient data to determine the outcomes of transition programs in pediatric surgery. I'll now turn over question number 3.
So now that we know that there's an ethical need to get a transitional program and what the outcomes are, we wanted to look at what the components of a transitional care program would entail. In 2011, the AP came out with a clinical report. It's published in 18 and updated in 22, where they described transitional care program needs, identified 6 core elements of a successful transition of care program from the medical standpoint. There's the website, the gottransitions.org, that provides resources for that, the medical aspect of it. So the 6 core elements you see there on the bottom: transition policy, transition tracking and monitoring, transition readiness, planning, the actual transfer, and then transition completion and feedback. So it's a process and it's a flow, and you see that they have a diagram for when ages start and how you move on to the next component of the transition process. So we reviewed the literature looking for these components. We found 32 papers. We included inflammatory bowel disease to help flesh out our information, given that it's a pediatric general surgical disease, even though some of it's managed by the gastroenterologists. And we found the papers that listed components specifically of transition programs. The types of studies were varied. They were varied from interviews to surveys. There were few comparative studies, as Rebecca alluded to. And the transition processes and the transition structures also varied widely. Some of them called one co-visit with an adult and pediatric provider a sufficient handoff, and some of them were multi-year, multi-visit processes. And we organized their reported components into the 6 core elements. So having a formal transition policy where you have a creation of a written guideline and the policy for your practice and something that you share with your patient, that was described in 9 of 32 total studies, and the majority of the pediatric surgery studies reported this. Tracking and monitoring, where you track the progress through the transitions, through each element of the transition process, where there's a formal written flow sheet or checklist. Oftentimes it's an EMR attachment. It's described in low amounts in all the studies. Transition readiness, where you assess the patient readiness to transition, starting at variable ages. And what this does is it sets priorities and prepares the patient for self-care. This is better represented in the studies that we looked at. transitional planning, and this is based on the information that you get from the tracking from before, and as well the transition readiness, where you have disease and transition-specific education, as well as the creation of a medical health summary, both for the patient and for the potential adult provider. I think Afif is going to come finish the rest of this.
So I'm just going to cover the last two proposed domains from the AAP in terms of how we can organize our thinking about transitional care. So this fifth component addresses the actual transfer of the patient from a pediatric specialist into adult care specialist. There are certainly many different ways that this can be achieved, different strategies or models to incorporate or integrate that patient. The most common one that we encountered in the literature is the use of a clinic where both a pediatric and adult provider are there at the same time. And this ranged from an instance where there might have been only one encounter, and that was the transition, to repeated encounters where these relationships were developed. This figure just graphically depicts some of the proposed transition models out there. This is from a review of the use of transitional care in congenital heart disease. And you can see here different styles of interfaces in terms of the specialists being involved and the overall timeline between their transition of care. The one that I did want to bring to everyone's attention in the bottom right is just the utility of having a transition coordinator. This is something that in the congenital heart disease literature has been found to be a very important and successful determinant of doing transition well, just because of the opportunity they have to develop this more longitudinal relationship with the patient that begins with their involvement with the pediatric specialist and then extends into their time with the adult specialist as well. The final component proposed by the AAP is just the completion of the transition, and this is, we conceptually think of this as closing the loop. This is the time where we ensure that the transition has happened successfully. Are these visits occurring? This is an opportunity for feedback. Is there anything that still needs to be addressed, any gaps that we should revisit, and making sure that these young adults have the care that they need moving forward. You'll also see that in terms of the studies that had this component represented in them, it was also our lowest proportion of studies that had data to support including this in their reported transition programs. To put this in the context of a more surgical specific disease, this is a framework that was proposed by ARMSNet, which is a consortium of European hospitals that deal with anorectal malformations. And this actually dovetails really well with the proposed AAP 6 domains. But the one unique component that we have to account for in surgical diseases is this factor that's in the bottom right. And it really harkens back to that introduction slide where we described that the biggest barrier for transition is the perceived lack of a qualified adult provider to be able to continue that care. And so one of the key components that they highlight in this study is the need to develop and commit to that expertise in adult specialists. You know, one of the big differences in terms of the care of the IBD patient and the congenital colorectal patient is those operations that we're able to perform for, let's say, the patient with Crohn's disease, it's the same operation that both pediatric and adult specialists were all trained to do, but as was alluded to earlier in terms of a complex colorectal patient, these are not operations that the adult specialists are necessarily familiar with. And so if we want to be able to transition these patients successfully, we need to commit to helping in terms of education, allowing them to be involved in our operating rooms, being involved in their operating rooms, so that we can continue to build that expertise for these patients to be cared for. So in summary, in terms of the components of successful transitional care programs in pediatric surgery, the literature, just like in the other questions, is very limited. There are numerous studies that describe and provide frameworks, but many of them lack all of the components that were suggested by the AAP, and we've described because of things that are very specific to surgery, there may need to be modifications to that framework as well. And so as a whole, there's really insufficient data to comment specifically on the components that make a transition program successful in pediatric surgery. You know, when we review all of this, the important thing is that the proof of concept exists. We know from the congenital heart disease literature, there's a prospective study going on called the Stepstone study, and in IBD, there's one called Transit. These are all great examples that have comparative data of patients who have undergone transitional care programs versus not, and have great outcomes and patient-related outcomes to support their use. We don't have to recreate the wheel here. There are a lot of frameworks that we are able to adopt to the care of our patients. As was described in the AA policy, the most important thing is to start, to write it down, to create a policy of how we're going to transition patients. Once you have that, you can move on to the next steps of how do we implement it, how do we measure it, how do we track our outcomes. It's important to build partnerships, not just with the adult specialists, but with the nursing, the social work, the psychologists that are going to be able to help provide comprehensive care of these teenagers and young adults. And again, developing the necessary expertise in our adult colleagues to help be able to provide appropriate care for them across the spectrum. So in conclusion, we can do better. There certainly is enough literature out there on gap analysis, needs assessments, and frameworks that it's time to move beyond that and really focus on the implementation science of how can we actually put these programs into action and how can we measure their outcomes. It'll be very important that incentives are aligned. I mean, this is hard work to transition a patient appropriately and safely. And there's been some work in terms of CPT codes being developed to help document and pay for this effort, but more work is going to need to be done to make this, for folks to get compensated appropriately for their efforts in trying to provide this important care for our patients. Overall, this field is very, very young, which makes it the perfect time to really do more research, work together, collaborate, and give the kids what they deserve. I'm going to introduce Dr. Katie Rowland from University of Chicago, who will be addressing the nuts and bolts from a quality and safety perspective.
All right, so hopefully at this point you have heard how important implementing some of these transition of care clinics are for our patients. I hope that some of you are inspired to go back to your home institution and maybe start working on how you can transition the care of some of your patients as they reach young adulthood and adolescence. So our goal as the Quality and Safety Committee was really to provide people with tools that they can use when they go home next week to start doing this and building these clinics right away. A successful healthcare transition improves the ability of youth and young adults to manage their own healthcare. And we really want to engage and enable both patients and their caregivers in the ownership of this process. When it's done successfully, it allows patients to effectively use healthcare services, maximize their long-term outcomes and the quality of their life, and reduce the loss to follow-up, especially as we recognize with some of these congenital conditions that they require ongoing oncology screening for the rest of their lives. But how do you do this as a very busy pediatric surgeon? We know that we need to do it because it's the right thing to do for our patients. We understand that we have a very unique understanding of the complex congenital anatomy and the repairs that these patients have had, as well as the factors that might influence complications that they have later in life or that affect their quality of life. But we can't do this alone, and it does require partnership with adult surgeons. This requires relationship building, as well as an ongoing open forum for discussion of complex cases between the pediatric and the adult world. It also is essential to engage the support of your leadership. There are financial benefits to this work, as were highlighted earlier, but this work does require administrative and social work support. There are many opportunities now within pediatric surgery for one to develop or build a center of excellence in long transition of care, because there are a few centers that are doing and specializing in this. In order to do this well, it also is going to require some outreach to our patients who maybe we have lost touch with, as well as to the pediatricians and primary care physicians who are providing ongoing care for those patients, to let them know that these transitions of care are important and to bring them back to our clinics. From the Quality and Safety Committee standpoint, we are going to show you some creation of templates that we've been involved with that can hopefully help you implement this again right away, so that the paperwork standpoint of this doesn't hinder you from doing this in your own practice. So one great resource that is not pediatric surgery specific is gottransition.org. This lists the 6 core elements that were discussed by the Outcomes Committee earlier. It also has great tools and timelines for implementation of transitions of care, measurements to see if your transition of care clinic is successful. As well, one of the topics listed under there is payment. There are CPT codes for transition of care services provided. These information can all be found on the gottransition.org website. So if you're thinking of bringing this back to your practice, take a few minutes and explore this website. But we also have tried to create pediatric surgery specific tools within our APSA QSC toolkit. So what is the Quality and Safety Committee Toolkit? Many of you may not have heard of this yet. It was created in 2019. It's an open access web-based repository of quality improvement projects that is actively maintained by the Quality and Safety Committee. The goal was to facilitate knowledge sharing in the development and implementation of QI projects that can be applied to one's local institution. So within each folder in the toolkit, there are evidence-based pathways and protocols, stakeholder presentations, and parent and patient education materials. It's really showing you all the behind-the-scenes work as well as the materials used at a quality improvement project so that you can pick up those materials and bring that same project to your institution and easily implement it. How do you get to the toolkit? The QR code is up here on the screen, but you can also easily Google. If you Google APSA QSC Toolkit, the toolkit is the first thing that pops up. There is also a link to this on APSA's website as well as in Not a Textbook. This is the home page of the toolkit. There are a lot of buttons up here. Each one represents a different pediatric surgery disease process or quality initiative. The transition of care is the folder that's highlighted in red. This is a new folder that was recently created this year in preparation for this meeting. So when you go into the transition of care toolkit folder, there's not much there yet, but it's growing. I would like to give a huge thanks to Dr. Alessandra Gassior from Nationwide Children's Hospital, who really is leading the field in transitioning patients with colorectal diseases from pediatric into adulthood care. And she was very generous to provide some of what they're doing at Nationwide, including PowerPoint presentations that go over how you can set up a transition of care clinic at your own institution, identifying key stakeholders. At Nationwide, the clinic that they have there starts the process of assessing their patients for readiness around 12 to 14 years of age. They administer the readiness transition tool to both caregivers as well as the patient themselves. And it allows them to be able to determine, by administering this on an annual basis, when a patient is 100% ready to assume medical responsibility. And what I loved about this when I talked to her about how she uses this tool is that she also identifies where patients aren't ready each year and helps them set a goal for things that they can work on over the next year so that by the following year when they take this readiness tool assessment, they have gained some skills to help them along their journey. There are 3 parts to the readiness assessment. The first part is just assessing how important the transition is to that patient and caregiver at the time and their confidence in being able to transition to adult doctor. The second aspect is assessing knowledge of one's own health. So making sure that the patient knows their medical needs, knows when and what the symptoms are that would require immediate attention, knows what medicines they take and why, and knows what their allergies are and to carry important medical information on them. The final part is assessing a patient's ability to use the healthcare system. So do they know their doctor's phone number? Do they know how to make their own appointments? Do they know how to get transportation to an appointment? Do they know how to fill out medical forms on their own? Do they know how to go to a pharmacy or get refills of their medication? Do they know how to get an x-ray done if one is ordered? Once it is determined that a patient is ready to transition care, one of the things that our committee wanted to, again, leave with people who are interested in doing this is a boarding pass or a document to use to really transition these patients' care into the adult world. And so with that, Dr. Bill Adamson will come up and show you all the boarding pass, which has been created and which can start to be used right away for patients who are ready to transition from the pediatric to the adult surgical care world.
Thanks, Katie. I think we've all had a chance to see how a smooth transition of care is going to improve outcomes for our patients. And I think we've seen some good examples of templates and other tools, particularly Dr. Gus, yours, that are helpful in helping to smooth this out. I think that all of us as pediatric surgeons are trying to help make our patients make a successful transition of care. And in this context, the Quality and Safety Committee has tried to create a template, sort of a master template of the information needed for transition. From the patient perspective, this requires encouraging patients to fill in and write down the information that they need for all the reasons we discussed before about having ownership. And then this type of template can also help the surgical team to anticipate the needs and gather the appropriate information for a successful transition of care. We're trying to create the essential elements of what would make up a boarding pass to a successful transition of care that includes all of the data that we need. So we've made a master template, which is now housed in the Quality of Safety Toolkit, that tries to incorporate all that data and then specify which data is needed for which specific condition. And so that a condition-specific handout, or the boarding pass, is created that you can work with your patient to be on the same page and move towards a successful transition. The first step, I think, is try to identify which general surgery conditions are needing to have a transition of care. Obviously, a lot of our surgeries are one and done, or we cure them, and they don't need a transition into the adult world. But many patients have ongoing needs, particularly the GI tract conditions. We've heard about Hirschsprungs, we've heard about anorectal malformations, the need for transition. We've heard about intestinal failure and IBD. In addition to these kinds of ongoing needs for GI perspective, there are also multidisciplinary problems with GI, GU, GYN for some of our more complex problems that need a transition plan as well. Some patients may not need additional surgery in the future. They may not need to be transitioned to a surgeon, but rather they may just need to be monitored for the potential problems such as potential cancer recurrence or for a malignant potential that can develop from the condition that we've already addressed. Think about colorectal cyst, undescended testicle, and CPAMs and patients like that that we worry about falling through the cracks. So once we've identified which conditions, we want to try to identify the types of data that we need in order to build this boarding pass for patients. So the boarding pass must include basic clinical information. It includes information gathered by the patient, which is demographic information, current clinical information, their labs, their meds, care plans. It also puts a little bit of burden on the patient or the patient and their caregiver to help identify future providers. As we heard before, that's one of the biggest barriers to a successful transition. But the surgeons have a role in trying to identify who these adult specialists are as well. Sometimes the other multidisciplinary team members, social work, nursing, home health are key players as well. On the surgical side, information gathered by the surgical team includes the appropriate, relevant op notes, radiology reports, pathology reports, other things. And then, as we all know, there must be, in some cases, specific data, clinical details about a surgery that need to be transmitted from a pediatric surgeon to the adult surgeon. So trying to put all of this together into a giant spreadsheet is a challenge, but basically we try to organize it where the elements, the pieces of data, are the columns of this spreadsheet, and then the rows are the individual surgical conditions. We started off making, in the first row, a master condition, and the master condition is an attempt to create all of the different elements that might be needed in the spreadsheet, and then as we create the disease-specific conditions, to pull them out. For example, under operative reports, there are lots of different kinds of operative reports. Some of these patients we've operated on many, many times. For example, a Hirschsprung's patient, you might want to have the operative report from the initial biopsy, and you definitely want the operative report from whatever the definitive pull-through procedure is. But in an IBD patient, you might be wanting to know the details from the ostomy takedown because that Crohn's patient might have a recurrence there. And so it's not all the same op notes. Similarly, the kind of data that we are asking the patients to provide is also important and disease or condition specific. For example, the relevant care plans that the patient provides and is able to elucidate in this template are crucially important for figuring out whether they've mastered their disease process, they understand, they're ready to move on. For example, can they explain their ostomy care, or I say patient, but patient and caregiver? Do they understand their feeding tube care? Do they have a consistent bowel regimen to address their constipation? Another column lists all potential specialists that might be involved in the transition process. And then the individual templates within a boarding pass for a specific disease are going to pull out which specialists are relevant. So on the side, there's a list of the surgical conditions, and for each surgical condition, a specific transition of care template is generated. Now, it looks sort of like this. There's not a surgeon or a patient that wants to go into this big template to try to find all this and kick it out. So somebody more facile than I, one of our surgery research residents, Molly McIsaac, went through this and was able to create a handout that basically is a one-click way for a surgeon to kick out this boarding pass and share it with their patient. And this is what that looks like. So this is the end result. If you go to this file on the Transition of Care Toolkit, you're going to come to this page. And all the surgeon needs to do is to go to the line at the top where the disease process is listed. There's a drop down there. You go down, you click on whatever the disease process that you're trying to create a boarding pass for is, in this case, inflammatory bowel disease, and then the rest of it kicks out. So there's, on the first page, instructions to the surgeon. There's also instructions to the patient and the caregiver to try to encourage them to fill this out as much as they can and what we're trying to get at. The green bordered parts are the parts that the patient needs to fill out, the demographic information, the current clinical data, including medications, current labs, also some of those care plans that we were talking about that might be relevant for this specific disease process. We'd like the patient to also try to identify, do you know who your adult gastroenterologist is going to be that we're going to transition you to? And we can, part of the job is for us to help them as much as we can. But if you'll also look, there's specific components here that might be relevant to that disease process that reminds both the patient and the surgeon that these are things that need to be thought about as you transition to adulthood. For a Crohn's patient, you're worried about sexual dysfunction later on. What about fertility? What about recurrence? We need to talk about all of those things. And for each patient, there's also a segment that says whether or not your disease process puts you at a higher risk for cancer or not. The blue is for the surgeons to gather, not necessarily to fill out. You could have, a surgeon can identify which pieces of information, which operative notes should we look for, and a member of your team could find those and print them out, and maybe attach them to the document. And finally, what I think is really important, there's a place where each surgeon could convey the details that she or he thinks are really important about the particular patient's operations that need to be conveyed to an adult surgeon later on. So when you finish with this, you can either print it out and give it to the patient as a template for them, an intake document in the clinic that they can then work with you to go over this and move forward, or you can save it as a editable PDF and present it to the patient after you've done your part, and then together you can work on it. But the idea is that we have a durable, editable, ever uploading or updating rather, template or boarding pass towards transition. To sum up what the goals of the Quality and Safety Committee are doing with the toolkit is that we recognize that both patients and caregivers need to understand and manage their own health care in order for a successful transition of care from us to the adult providers. And this boarding pass and the educational resources that are also in the transition of care are going to help us to be able to provide that information and do a good job for that with our patients. What's next? What are you going to take from this? What can you go back and do? You might be able to identify conditions at your center that you would like to be seen as a center of excellence in your particular area of expertise. You might be able to use some of the outcomes data that was discussed and some of the templates to enlist administrative support or buy-in. It might help you to set up that transition of care clinic that some institutions have the luxury of having. You can download the transition of care toolkit. You can even track and publish your results. But I hope that some of these resources are going to be able to do the most important thing, and that is to ensure the bond between you and your patient in trying to complete a successful transition of care to the adults that are going to be taking care of this patient for the rest of their lives. I guess we have some time left over for questions. I think any of us are happy to take questions.
Hi there, good afternoon. Paul Osti, Liverpool, Bangkok, Thailand. Just some comments. We've written quite a bit about this, and actually transitioning begins with the fetal clinic, to be quite honest with you, because at fetal clinics, you have the multi-discipline specialists, the obstetricians and neonatologists, the surgeon and the other partners that go with that. So, and with that, from birth, transitioning is already taking place, with multidisciplinary clinics, which we've run at my hospitals for over 30 years for these rare diseases, that transitioning is gradually taking place. And right up to the ages of 18, that journey is quite an adaptive one for the patient and the family. And, you know, in Nordic countries, they have centers for rare diseases where pediatric surgeons are seeing their patients at 40 and 50 with these various conditions. And in fact, if I was starting my careers again as a pediatric surgeon, I cannot think of a better job plan than to be caring for my patient from birth to well beyond as they approach the end of life. And in fact, I think that's our duty, because the successes we have achieved are very much our responsibility. And if we can do these clinics in our pediatric hospitals, it's not impossible to do it in the adult hospitals within networks that you can build. In other words, the pediatric surgeon is a visiting surgeon at the adult hospital or within that network, and you make something which sounds challenging very easy and possible. So there are just some comments for you that this, certainly across the Atlantic, this has taken off for quite a number of years. And indeed, the surgeon transitioning with the patient, having a job plan between an adult and a pediatric hospital makes it all possible. And I think that's a great way to do it.
I would agree. I think there are lots of challenges in the various practice settings in which pediatric surgeons practice, and so each of us is in a unique institution. Some of us might be in a freestanding children's hospital that may or may not have an academic connection with an adult academic hospital. Some of us might be in private practice in a pediatric surgery or a freestanding children's hospital. So there is no one way to do this. Everyone's way of transitioning their patients is going to look different because everyone's practice model looks a little bit different, and the people within their area who they have to refer to on this adult side and build those relationships might look different. But it's important for us to think about and be intentional about, and again, plan for from birth, because if you're doing it well and keeping these children's records well from their very first operation, it becomes much easier then when the time for transition is ready to happen to have the information that's necessary ready to go to transition care. In the same way you would transition care if you were at the end of your career and handing off one of your patients who was still a pediatric patient to one of your more junior colleagues. So there's lots of times when we have to transition care of these patients and to think about how we can do that thoughtfully.
Hi, Jim Pierce, Valley Children's. Fantastic presentation, and I really look forward to utilizing the toolkit. I had a question actually about another fantastic resource, which is nurses and nurse practitioners. As we all know, we rely very heavily on them to help us both in our patients who are under 18 as well as the older patients who need to get back in to see us for a variety of reasons. Have we reached into the nursing literature to see what was available, or the committee looked into the nursing literature? And have we leaned on our nurses and nurse practitioners and PAs within our own society to learn additional things that we can do, as they're a humongous part of our clinical practice? Thank you.
Thank you for that question. Our literature review did include nursing literature. There is a lot of kind of semi-qualitative work, but there is not a lot of fully structured programs that they have written about. In terms of involving nurses and nurse practitioners, there has been collaboration that our group has done to work for specific cares that the nursing group has established. For example, DME ordering. That's some of the stuff that adult surgeons don't want to be responsible for, but that falls within the purview of a pediatric surgical clinic, is to order all of those supplies. And so our nurses have reached out to other practices, and they become the liaison to essentially give the different product numbers so that it does not become a burden on the office that they're transitioning to. I would say, though, that when you look at a lot of the literature of just how programs are implemented, in a lot of the European literature, the family practice doctor really becomes like the hub of where the transition care occurs from, kind of almost like the lead person for that transition. And so that has been a lot of work that our nurses and nurse practitioners have done, is to talk to any office, and sometimes these are more internal medicine family practice offices that can provide that information.
I just wanted to add that that role of transition coordinator is in many cases filled by a nurse or an NP. And while we have limited examples of it in kind of what we'd consider index general pediatric surgery, certainly in congenital heart, I mean, they really push for this. And some people would say that the bare minimum that you need to have like a transitional care program is a written policy, is some kind of passport so that the patient has information about what surgeries they've done and their ongoing care, and the presence of a transitional coordinator. Like those three components are probably the most important. And so, I agree with you 100% that collaborating with our nurses and nurse practitioners to ensure that this coordination of care is happening will be critical for this to be successful.
Hi, Erin Teeple from Children's National. I am a pediatric surgeon. I'm also an adult colorectal surgeon. I split my time between Children's National and the MedStar group, so I am walking this walk of transition. One of the biggest barriers that I run into is who's going to pay for it. These children are often Medicaid federally funded. This does not cross state lines often. And although a transition coordinator is a great idea, and we know that it reduces recidivism and it improves outcomes and keeps people out of the hospital, that doesn't generate funds for these hospitals. Have you thought about maybe other ways that we can pay for it? Institutional buy-in, as you mentioned, but particularly as a surgeon, it's hard for me to hand off to a surgeon because it's non-RVU generating work. So I think advanced practice providers are a good bridge for that. They can often bill and make their own salary. And often adult colorectal surgeons, our surgeries are sort of done, and it is a lot of bowel management. So sometimes maybe collaborating with a GI physician or a GI nurse practitioner is another way to do it. Have you thought about the financial pieces of that? And number two, I like this boarding pass. I think a lot of my young adults would prefer an electronic version. There are apps for that, so that's something to think about as we're transitioning our young adults. There are a lot of great apps that they can record their history on, and we can help them do that as part of the transition readiness. So thank you for this tremendous work. I think it's long overdue. Obviously, I have a biased opinion, but I really appreciate the thoughtfulness around this.
Thanks, Aaron. I think making it into an app is a great idea, and that's something we could work forward to. I think we all realize, both comments, about how important the advanced practice providers are to making the transitions and everything in our practice go smoothly. I have seen very little. I don't know if the outcomes committee members have seen anything on who's going to pay for it. I don't know that those data are out there, but documenting the cost of this in preliminary studies is going to be the first step, as we've seen with other disease processes that are not reimbursed very well.
I would say that the closest we get to any kind of financial information is decreased healthcare utilization by the patients who have gone through this transition clinic. But, you know, the actual reimbursement is not anything that we were able to identify in the literature.
Sorry, I'd add that if you like reading papers, that AAP kind of domains on transitions of care is a really nice framework of how to think through this. And they spend the better part of the entire last page about kind of aligning financial incentives, because like you said, if the financial incentives are not there, it's very hard to see this really taking off and getting done appropriately, because people need to be compensated, I think, for their time. They've discussed that there has been the introduction of, I don't know, a couple of CPT codes that kind of do pay for some aspects of transition, but certainly not enough to cover the time it takes. And so I think from an advocacy and an AAP and kind of the folks that work with kind of RVUs and CPT codes, there's certainly a lot of work that needs to be done still for this to become more of a reality and more embedded into our daily practices.
The CPT codes are listed on the gottransition.org website as well. That's something that we can add to the toolkit. It's not perfect, but we'll get it there so that you can have that as a resource. As well, what was recommended for patients who perhaps don't need a surgeon, but a GI doctor, some of the GI doctors who specialize in motility disorders have been great partners for transitioning some of these patients. So if you're looking for a person to partner with for transitions, I'll perhaps look to see if you have a GI motility specialist in the adult world nearby you.
In the interest of time, we just have time for one more question.
David Rothstein from Seattle Children's. It's heartening to see the work that's going on here, but it's also disheartening to see how hard it is to get it done. You put up a seminal paper from the Pediatrics by White et al. About transition, and they did a study 10 years later that showed only a third of the kids with complex chronic conditions had achieved any kind of discussion of a plan, let alone have a formative plan. So the question to you is, how can we monitor our progress? Is there going to be some way to capture a database to see how things are working, to abstract which ones are successful, and not have to rely on people like our previous speaker and Dr. Gassier, who are a one-stop shop for that kind of transition of care? But thanks for doing all this.
I think that's part of the reason that the last core tenet of transition of care is ensuring transfer completion, getting feedback from the patient, closing the loop on the transfer of care, making sure that that's happened.